how much attention the ACA has gotten. And that attention has focused on financing, coverage, exchanges, the Cadillac tax, really focused on the financial part of the ACA. And I think more and more employers now recognize that making decisions about financing healthcare is different than making decisions about managing health and its outcomes in the workforce. And so I was really pleased when we had the chance to discuss with UnitedHealthcare this plenary session around, given the ACA, how do employers continue to develop and maintain a healthy and productive workforce. So I'd like to introduce who will moderate the panel, Don Potter from UnitedHealthcare, VP of Client Relations. Don?
Well, standing up here, I'm a little worried with all of you in the back that I feel like a bad preacher on a Sunday morning. So I'm hopeful that through this session and from my remarks, I'll be able to keep those of you in the back engaged. And if you're so inclined, maybe you'll want to move forward. So I'm going to start like a preacher, and I'm going to say 3 things to you. 10 years, Jimmy Buffett, and the Dream Team. So you're sitting there, it's Tuesday morning, many of you have jet lag, and you're thinking, what does 10 years, Jimmy Buffett, and the Dream Team have to do with the ACA and wellness and productivity? And how are we going to tie it all together? Well, let me start, and I'll take each one. It was 10 years ago, through 2 people, Peg Henneke and John Miskell, who introduced me to Tom Perry and IBI. And back then, those of us in the health plan business were struggling with our plan sponsor customers with concepts like engagement, disease management, care management, plan compliance. And the questions that many plan sponsors were asking was, how can we engage our workforce in these programs and keep them engaged? How do we deal with these programs and link them to concepts of absence and productivity? And it was Peg who said to me, Don, the most effective way to ensure compliance in a care and disease management program is to put your absence and disability programs on steroids. And I said, you're kidding me. And she said, let me tell you why. 3 reasons. Number 1, in almost all employer absence, a primary or a secondary condition is a health-related event. Secondly, unlike in the health plan world, in the absence world, we get to engage the plan sponsor when talking about the claimant and return to work. And thirdly, she said, in the absence world, we have the most effective compliance tool of all. We are part of the pay process. So you know what? When I think back 10 years, she was right. And today, IBI and PEG and others like her are using and integrating the data around care management, disease management, absence and productivity to fashion and design health and absence programs designed to increase compliance in care and disease management. So that brings me to Jimmy Buffett. Let me see a raise of hands. How many of you in this room are Jimmy Buffett fans? Awesome. Now, in tribute to a very good friend of mine, I'm going to try to tie Jimmy Buffett and his song, A Pirate Looks at 40, to absence and productivity. So you may know, if you know the song and you know the words, there's a particular stanza that says, yes, I am a pirate, 200 years too late. The cannons don't thunder, there's nothing to plunder. I'm an over 40 victim of fate, arriving too late, arriving too late. So what does that song and those words have to do with our session this morning? Well, just like the observation made by Peg and the challenges we're now all being faced and having imposed on us by ACA, in the Jimmy Buffett case, he waited until he was 40 years old to address issues in his life. It was too late once he finally got up the gumption to address them. We in this room don't have the luxury of waiting. We need to again place our absence, productivity, and our health programs on steroids and be creative about how we will address those problems in the face of ACA. We cannot allow ourselves to arrive too late. Through this session this morning, hopefully we will arrive early. So finally, that leads us to a dream team. Maria talked about her dream team. Well, we're going to bring a dream team up to the stage this morning. And this integrated health and productivity team begins with Dr. Dick Migliori. Dick? Dick is the Chief Medical Officer for UnitedHealth Group. In Dick's role, he oversees clinical policy and clinical innovation across all of United's businesses, whether it be UnitedHealthcare, United's benefits business, or Optum Health, which is our health services business. Our second panelist is Dr. Josh Riff, who is presently Target Corporation's medical director and also, interestingly, heads up their benefits area. Imagine the clinical and innovation conversations one gets to have with someone like Josh. He's a leading voice in patient and consumer empowerment and has also written a book on the role of retail and convenience clinic medicine in today's marketplace. Our third panelist is Mary Tavarozzi. Many of you all know Mary as the past chairman of the IBI board, but she is also the North American practice leader for Towers Watson's absence and disability business and has been a wonderful friend to many of us in the business in helping us understand the linkages between health and absence. We're lucky to have our fourth panelist, Dave North. Dave is the president and CEO of Sedgwick, and under his leadership, Sedgwick has grown to be the largest TPA in the industry. Like Josh, he too has written a book on the art of self-insurance. And lastly, I'm pleased to introduce Jennifer Bruno. Jennifer is the general manager of Wellness and Prevention, Inc., which is a subsidiary of Johnson & Johnson. Jennifer oversees all aspects of wellness and prevention operations and also serves on the IBI board of directors. Please welcome our panel for discussion this morning. A couple of ground rules. I've asked each panelist to share briefly their point of view as it relates to ACA, wellness, and health from their chair, and then I will moderate a series of questions. We do have an opportunity for each of you, however, to ask our dream team your questions, and I'm hopeful that you will engage from the various microphones that are out in the audience. So let me start with Dick. I'm going to turn it over to you. Perhaps from a UnitedHealthcare perspective, you could share our view relative to ACA and wellness and productivity.
Thanks, Don, and thanks for the nice introduction. Let me take that topic in two parts. First one is productivity itself. And I think one of the things that's happened with UnitedHealth Group is its growing appreciation for the importance of productivity, its measurement, and its influence. And nowhere did that become more sharpened and focused than with one of our most recent clients, where productivity is life and death. That's the Department of Defense. Let me quote Vice Admiral Matthew Nathan, who at the time the Surgeon General of the Navy. He described that the medical systems of the Department of Defense, and therefore the TRICARE contractors as well, is having a job of readiness. In wartime, that means battlefield ready. In peacetime, it means ready so that they can train. when the other eventuality occurs. We started looking at those comments and our commitment to the Department of Defense, started realizing, isn't that our value proposition for everybody we serve? Going beyond trend containment, going beyond improving health status, but in fact, making them competitive in their day-to-day work. And we owe that to our clients. That means we have to be able to measure it. In terms of the ACA and its influence is a different ballgame. The ACA is a real opportunity. It encodes something in law we've been trying to do for a long time. It encodes in law personal accountability, starting with everybody under penalty of a tax has to be able to buy health insurance. They're responsible for acquiring their own health insurance. Well, that level, irrespective if people are buying it for themselves or they continue to have access to an employer-sponsored plan, changed the rules. What it did was to cause people, whether they're getting their care through exchanges, to have to make an active step to decide how they're going to do it, whether they're subsidized or not, whether they're commercial or in the Medicaid space. They end up having to make a decision. That makes the next decision easier. And because they have a price sensitivity that's personal, they're going to probably, and if we can encourage them and give them faith, they're going to be working with wellness and a variety of things to become more accountable, make better decisions to contain their costs. For those with employer-sponsored plans, they now have a different appreciation for the burden that's been taken off of their shoulders to do this because their employer is providing them with something for which there's a newfound appreciation. The ability to get these kinds of services on their behalf. It's an opportunity for the employer, for us as their carrier, to be able to provide confidence to those individuals that if they take that accountable step, they're going to be able to perpetuate that employer-sponsored plan. Let's put it all together. We've done some interesting work, and I saw Randy Ford out here. We did some interesting work where we shared data with Unum. And what we did was compared our proprietary Consumer Activation Index. It's a simple weighted test to look at the kinds of decisions that individuals make about their health care, the financial, the service-seeking, the clinical aspects of consumer decision-making. And what we found was something very interesting, and it's preliminary and it deserves further work. But it looks as though there's an inverse relationship to a higher Consumer Activation Index, meaning better decisions, an inverse relationship between that Consumer Activation Index and the number of disability episodes and their length. We think by getting people engaged in an environment that the ACA is now promoting is a way in which we can get people on the right track and helping their employer, the workforce, become more effective on their own battlefields.
Thank you, Dick. Josh, from an employer perspective?
Yeah, so when I look at ACA, I look at it from two different hats. One is wearing my benefits hat as the Director of Health and Wellbeing for Target, and the other when I put on my emergency medicine hat as I'm still an occasionally practicing physician. And no matter which way you look at it, the ACA is something, whether you're for it or against it, it's a reality. And so as an employer, you have to adapt. And I think the first advice I have is to really make sure that you have your compliance teams, if not your own internal teams, be working with your payer or a consultant to really truly understand ACA. And I think for us, the first part of the battle was really understanding. We probably spent upwards to 2 years really understanding what's the definition of a seasonal employee, what's the hourly, the monthly hourly limit, how does that affect us? When we rehire somebody, how does that change our policies? And so the biggest advice I have is just make sure that you have your house in order. When I look at it from a bigger perspective, though, what the ACA did is it really opened up my eyes to how limited just the aspect of who provides your health insurance is for the holistic team member or the employee. And so this is so true for the IBI when you think about where productivity and disability come into it. So if you as a department, your benefits department, are solely focused on those people who have health insurance through you, you could miss a whole other part of your population, whether they be part-time or seasonal people who don't get health insurance through you. And so you lose control or you lose sight of that, the whole aspect of productivity and disability. And the greatest example where this kind of hit home was when as you've seen a lot of payers going to the exchange. So for example, Walgreens, when they went to the exchange, of course, it activated a lot of interest at Target, and they said, well, what does this mean? And so we explained it, and one of our senior executives said, so let me understand this. So right now, we have basically 90% of our lives with one payer. If I want to control back pain or back injuries, I could pick up a phone and call that one payer, and I have a lot of purchasing power with that one employer, with that one payer. If we go to the exchange, do we lose that? And I said, absolutely. And kind of a light bulb went off. Because for us, we really care. A great example is with elective inductions. We really don't want our female team members to be electively induced, because if you have elective induction, it increases your chances of having a C-section. Now, it's not the cost of the C-section that concerns us. It's the extra 4 weeks of disability, or of the short-term disability. Now, that's a complete different department from the health department that I run, but that's what we have to start thinking about. So what the ACA really did for me, and I encourage for all of you to do the same, is start thinking about what's your social contract with your team members or your employees, and say, what wellness services do you want to offer everybody, regardless of who insures them, because who knows where we're going to go with the ACA, right? Like, so now they're mandating how many hours, and we're being mandated on the seasonality, et cetera, and what's covered, what's not covered, what's preventive, what's not. But as this progresses, could create a larger chasm between us and our employees. And so what we've decided to do is say, well, what's good for every employee? And so if a healthy back or healthy pregnancy program is good for everyone, regardless of your insurance status, we want to work to offer you it. And we've started slowly, for example, with flu shots. We've said we don't care what your insurance status is. We'll give anybody a flu shot. And we're starting to roll out more and more programs. And for us, the ACA was really a galvanizing point to say, you know what, let's stop thinking of it just in terms of insured and uninsured, but let's look at actually our entire population and say, what can we do for everybody that's good for the holistic organization as well as the whole person.
Josh, that's awesome. So I'm sure, Mary, you may have a different perspective from your chair. You've heard about integration. Perhaps you can give us a Towers Watson or a consultant's point of view.
Thanks, Don. Good morning, everybody. Well, from a consultant point of view, we've been working with employers both before the Healthcare Act passed and since that time to address the challenges of what are they going to do under healthcare reform. The fundamental question that many are addressing, and you heard this from Bill yesterday, is what is our role, if any, as a plan sponsor of healthcare for employees going forward? Another important element is, how do we get on a glide path to 2018? Question for you benefit professionals out there, how many annual enrollments do we have before the annual enrollment for 2018? 3. So if you are in the process of trying to make a series of changes, which most of our employer clients are, and you've got 3 open enrollments before the final one that's coming up, and you don't want to have a huge disruption of your workforce, then you are engaged in the strategy right now of a series of changes that will tackle health and productivity issues and prepare you for that crucial 2018 year, which as far as we know is not being delayed, but who knows?
Who knows?
Well, 2018 won't be delayed, but what happens might be delayed. So those are really the challenges, and my team at Towers Watson that I'm very fortunate to lead, and many of the folks are here today, our major focus is on productivity, but our colleagues at Towers obviously are also focused on the healthcare challenges. And I'll admit it's been tough to get the attention of the employers in terms of thinking through the productivity impacts of the decisions they're making around healthcare. And, you know, we're kind of pests in a way because we're saying, please pay attention to this. The decisions you're making now to prepare yourself for healthcare reform will have a fundamental impact on productivity for your workforce. So you have to think of this holistically as you are making these decisions and you're moving forward. One of the benefits, I think, of the healthcare reform, as my panelist colleagues have said, it really provides a lot of support in the areas of financial incentives, consumerism, employee accountability. And I know a lot of the employers in this room have been focused on building that culture of health for a while. And I think these are great tools, also with cost transparency and more decision support tools being made available that will help employees become better consumers. So whatever strategy the employer ends up with in terms of addressing what to do under healthcare reform from a healthcare delivery or program aspect, the employer must be aware that a healthy workforce, mentally and physically healthy, is really the essential building block for productivity. So the strategy has to focus on delivering the best healthcare value along with the decision support tools and the processes that will lead to achieving optimal productivity.
Thanks, Mary. Now, Dave, I've got to imagine you've heard health, 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 and you're in the absence, productivity, and workers' comp business. Maybe you could give us a Sedgwick view.
Yeah, so when I think about the Affordable Care Act, to me, thinking about it from the integrated standpoint of it, not the health plan itself, what concerns me is not what's in the context of the actual law itself and the regulations that be developed, but the opportunities that it creates for all of us in the other areas that we deal with. Because we deal with family medical leave and short-term and long-term disability and workers' compensation. And clearly, when a law with such magnitude as the Affordable Care Act, it's going to change fundamentally how we access care, reimbursement, and quality of care. That's clear. It's embedded in the regulations. Starting to figure all that out. Professionals like these are starting to take it into our employment, into our workforces. But the inside embedded in there is enormous opportunity, I think, for us to address some of the other issues that we deal with. There's conversations that go on in the Affordable Care Act about the shortage of physicians. And I'm sure mathematically that's true. But when I think about it from a workers' comp standpoint, for example, I think about innovative ways about telemedicine and the use of PAs and nurse practitioners and alternative delivery mechanisms. And while there's so much discussion going on in the industry about the Affordable Care Act, is that maybe an opportunity for us to get a point of view in that says, in this part of the world that healthcare impacts, is there a way to change things? Wellness, another area that's well embedded in the Affordable Care Act, has incredible incentives for employees to participate in wellness plans. We don't enjoy those incentives in a lot of the other integrated plans that we deal with. So I think about, is there a way for us to capitalize on that? Not bring incentives into work comp or into family medical leave, but capitalize on the integrated view that all of us have about how these occur. So not treat Affordable Care Act as a separate, isolated island that only the benefits people are dealing with, but view it as an impact on one of the largest, most impactful areas that affect the rest of our areas, which is healthcare itself. And find areas within the Affordable Care Act for us to capitalize on and reform the other parts of our integrated approach. I think Bill said it yesterday in his final comment when asked the question about the Affordable Care Act. He said he was optimistic. I'm optimistic. I'm not optimistic because of what's contained in the legislation itself. That's debatable, and people are going to continue to refine that and work on that and politicize that for years. I'm optimistic because it's causing a dialogue amongst all of us that allows us to think about our perspectives on how care affects what we do. And maybe in the work comp area, stop focusing so much on managed care and focus a lot more about the health care, even in the work comp arena. And I think ACA causes an opportunity for that.
Thank you, Dave. And Jennifer, now you're going to bring it all together from a point of view on wellness and prevention.
I don't know about that, bring it all together, but I will round out the panel this morning. Good morning, everybody. I am with Wellness and Prevention. That's a division of Johnson & Johnson, and it's a commercial business that actually focuses on helping organizations renew the health, the energy and the performance of their employees and members. But I have been with Johnson & Johnson close to 30 years, and the majority of my career has been in our own employee wellness program. We have 128,000 employees around the world, and I've had responsibility for the initiatives that we've been rolling out and the outcomes that we've seen for our own employee programs. What I would have to tell you, though, coming from either of those two perspectives right now, is I have never seen the pace of change that I have seen recently as it relates to employee health. And when you look at what's going on right now with healthcare reform, with legislation, when you look at what's going on with technology, the pace, frankly, has just been breathtaking. And in fact, for me, it's about as breathtaking as it was for me to walk up Powell Street this morning from the Sir Francis Drake Hotel all the way up here to the Fairmont. I was dying by the time I got here. And I would tell you, I think the ACA in general is causing a lot of that pace and that breathlessness for folks. But what I will tell you is every hill I got to the top of, and I had to wait for the light to change, it gave me a chance to pause. It gave me a chance to breathe. And what I would tell you that I'm seeing with the employer customers that we work with in our wellness and prevention business is the ACA has changed the conversation. It's actually allowed for that opportunity, that impetus to change that Tom referred to yesterday afternoon. It's allowed people to pause for a moment, waiting for changes to come out, the legislations to become clear, for them to really think about what it is that they're doing for their employees, be very intentional about what they're doing. And what we're seeing mainly is that this pause is allowing a strategic alignment to go on in the organization. So it's not just about the finances, it's not just about the benefits, but it's about where does employee health and wellness, where does performance fit in the overall strategy of the business and in the organization. And I think it's actually elevated the importance of health and wellness. So while I see the ACA as something that's caused many of us to be breathless and have a whole lot of uncertainty, I do think it's an opportunity for us to really focus on not only reducing the healthcare cost issues that we have here in the U.S., but helping our American public, our employees, really improve their health.
What's fascinating, I think, for all of you is how this panel is viewing the ambiguity perhaps associated with ACA and is choosing to look at it opportunistically to take advantage of what this law potentially portends for us as opposed to the challenges it provides. Again, I just want to reinforce this is an opportunity for you all to ask some questions too, but as moderator, I'm going to open with a question, and I'm going to start with you, Dr. Migliori. And one of the concerns we do get from many customers about ACA is physician shortage and how their employees are going to get access to the quality care given the influx of 30 million potential new patients. What does UnitedHealthcare view, or what does the health industry view as possible solutions to this? Is the physician shortage real? And what are some alternative opportunities to take advantage of that?
Thanks, Don. The physician shortage is real if you live in a world in which the care delivery model stays the same. And looking at it that way, even the American Association of Medical Colleges believes there were about 45,000 just primary care physicians short of what we need to be. And that's only going to be made worse and sooner as more people enter the covered market space and they start attending to issues that when they were paying cash could put on the back shelf. The solution for that, we believe, is an investment. It's investment in three things. Number one, technology, and David said it well. To be able to start looking at changes in the distribution of medical science and its application through telemedicine, through outreach programs, through connectivity over great distances. And we're going to see now the necessity of that make telemedicine, which has been real for a long time, actually something that people use, including on demand from home in the middle of the night. The second place of investment is actually investing in capabilities that's very proximate to workplace, clinics, within the workplace, clinics near the campus. But it can't just be a clinic alone. It really has to be an open-arm concierge model. And when we've done this, we've tried to focus on those clinics doing three things. Number one, being a place for care, as you typically would think, but also being a place for advice. So when people use the healthcare system, they use the best parts of it when it goes beyond the clinic for surgery and the like. The third thing is a place for engagement. And that's the place in which you get people focusing on their risk factors, changing lifestyle, and having some accountability to a coach of some sort that allows them to get that going. And we're seeing that really take off. The final investment that we talk about is one in actual wellness programs. Really getting people using massive data, as you said earlier, to start putting together some ability to help people find risk. And the one thing that we're finding lately that's been a pleasant surprise to us is the use of data other than claims data to help find people in need early on before claims are generated. The use of dental data, the use of vision data, the use of disability data, as David and I were talking about earlier. All our evidence includes that there is something that can be addressed now and nip it in the bud, biometrics even. All of those things to help us identify disease early, nip it in the bud, and do things to mitigate the risk of having to access the system. The final thing is going to be a need for policy change in two forms, one of which is interoperability across health systems. People do migrate. There is a need for exchange of ideas. It's got to be done securely, but that's important. The second is allowing people to practice at the top of their license to improve the capacity. We will not catch up by trying to train doctors the way in which they've been trained, even in new care delivery models. We really have to design ourselves around well-integrated teams with shared responsibility. Nurse practitioners and lower in the system.
Yeah, and Dick, I'll pile on to that. One is the clinician. I mean, as when I used to be medical director for retail clinics, I'd argue 50 to 60% of what a primary care doc was doing, our nurse practitioner or PA could have done, and what an NP or PA does, a nurse could do, right, or even a tech. The second one where I'd add is technology. So I gave a talk called Do-It-Yourself Patient, the Do-It-Yourself Patient. And we're looking at home strep tests. There's a company that's just sent me an application for your phone to look in your ear. There's all of these great technologies from the home, and we have to, work with the FDA to make sure that it gets approved, work with people like Dr. Migliori to make sure it gets paid. But when we could get this into the hands of the patient, I believe that we could transfer a lot of the care out of the office into the home. And that's what we truly, truly need as a nation, because we are not showing enough motivation to actually get our care. And what's interesting is I'm a big fan of telemedicine, but I'm always saying every telemedicine company focuses on the acute and episodic. And so when you have a dental ache, you are toothache, you are the most motivated to go see your doctor. Same with sinusitis, same with when your kid has ear pain. So you're highly, highly motivated to seek care, but we try to make it really convenient. What I'm looking for is a shift where we have things like endocrinology, oncology, those follow-up, cardiology, the follow-up that our patients or our team members aren't necessarily doing, and let's make it easy and convenient for them. And I think when we have that paradigm shift in telemedicine, I think that's when we'll actually kind of get over that, what we would call the tipping point.
Dave, just to add a comment on that, as we think about this issue about the availability of physicians and the settings that's going on, I think you have to look at it sometimes from the physician standpoint, and the economics of that profession these days are really getting out of whack. When you start talking to young physicians or college grads that are thinking about going into medical school, I think for me, taking it back to what we do for a living, we have to start thinking about rationalizing the reimbursement. Now, I'm not talking about taking on Medicare, Medicaid, changing the way the Affordable Care Act wants to reimburse it. I get that that's complex and it's, greatly conceived in Washington and then spread around the country. But in workers' compensation, we have reimbursement rates that are significantly higher in many cases, and yet it's not giving us better health care. And so, to me, looking through the reimbursement mechanisms and start thinking about how are we causing our employees and our clients to use and consume health care so that we can use the reimbursement systems appropriately to get to the right treatment at the right time. In work comp, we are horrible at overuse of the system for the majority of the cases. The small work comp claims, we access the system, we want, primary care physicians, the best of them, and everything. We don't need that. We should treat them at the plant. But we're underutilizing the system at the high chronic ends that the healthcare system is so good at sorting those out. And work comp, we're terrible. We keep forcing them back in the general system. So again, to me, all of the issues for the Affordable Care Act are opportunities for us to step back, take norms that we always used and say, maybe it doesn't need to be that way. I know there may be some statutory or regulatory change that has to occur, but we have a large voice. We can change it over time.
Let's take the workers' comp piece, Dave, for a moment, because workers' comp is not mentioned in ACA. Good for you. But are there, other than what we've talked about, are there other tactics or considerations employers should be looking at or thinking about as it relates to work comp in a post-ACA world?
Sure. I mean, I would say basically people who say I don't have to worry about the Affordable Care Act in my work comp program because work comp is not mentioned are making a huge mistake, because the care that we consume in work comp is created in the general health care system in the United States. We just access a small component of it. So what is going on in the Affordable Care Act and healthcare generally, what corporations and what the healthcare providers are doing is critically important to the ACA side. We should have a voice in that. We should express new ways that we want to access it. If telemedicine, for example, is an area that we think is a viable way to treat a significant component of the work comp system, we should express that, because as people like the other panelists are trying to decide how to restructure the care system in the country to match the Affordable Care Act, we can help them meet our needs in work comp. So I say to the comp people in the room, this is critical to us, maybe even more critical because we don't have a voice in it at this point, and we have to speak up and know what we're looking for.
Terrific.
And I just want to add to what Dave said here is that as employers are increasingly designing health programs that put a lot more cost sharing, on the employee and, high deductible health plans in particular, there is an opportunity there for employees to sometimes decide that a medical condition is work-related rather than paying first dollar out of pocket as they will in high deductible health plans. So we are working diligently with employers to think through all the implications of that, and not to necessarily turn away from that model, but to be cognizant and aware and make sure that their suppliers are aware of what they're doing in the event that we start to see some blurring of the lines or leakage over into one system. And I think the other thing in terms of workers' comp, but also disability with the potential physician shortage, is to think about employers working together with their disability and work comp suppliers to think about some of the requirements you have right now that employees must go through to prove their disability. Mm-hmm. I was in my doctor's office a few weeks ago, and on the back of the exam room door is a sign that says FMLA forms $10, short-term disability forms $25, workers' comp, see another doctor. So, if we are requiring, and we continue that paradigm of requiring these forms to be filled out repeatedly throughout a disability or work comp event, are we inadvertently exacerbating this problem about access to care, and are we sending the wrong message?
Mary, changing the subject a bit, one of the things about ACA is this thing called exchanges. And I know many of us in the room are either dealing with it, considering it, being told about it, et cetera. Towers Watson is in that business, as is many others in the audience. But from a wellness and a health and productivity perspective, Do you have a point of view on strategies employers should think about as they consider the exchange marketplace?
Well, there's a lot of interest in exchanges. You know, there has not been a lot of adoption of exchanges yet, and I think like many aspects of the Affordable Care Act, we'll see how this plays out over time in terms of what percentage of the employer population will pursue a private exchange or even exit plan sponsorship and possibly send employees to public exchanges. A high-performing private exchange is going to provide an employer with access to best-in-class programs and resources that support and promote wellness, health improvement, good consumerism, et cetera. But at the same time, the employer still controls most of the aspects around productivity. And so one thing that I would say to employers, regardless of, you know, you're thinking of the exchange or going to the exchange or not going to an exchange, you know, you control a lot of the productivity levers that I call them. And one of those is around plan design. I think everybody is focusing on consumerism models for healthcare. If the last time you updated your disability design was in the George W. Bush administration, the chances are that it's not a very consumer-driven design. And it's time, well past time for you to take a look at that as one of the aspects of productivity. And then employers also can still contribute tactics and levers of productivity in such ways as, you know, the on-site health centers or near-site health centers, you know, cafeteria and vending machine choices, screening programs. But the big elephant in the room that employers can still have a big impact on is the issue of employee stress. And if we are serious about tackling that, we are helping to contribute to improving overall productivity.
So in other words, and maybe Jennifer, you'd have a point of view. So Mary, you're also saying behavioral health, EAP programs are critical. Jennifer?
Oh, absolutely agree with that. You know, I read a recent statistic that, you know, at least 40% of employers have employee assistance programs, and that number continues to grow today, while 70% and better of employers are offering wellness programs in general. Somehow, we haven't necessarily made that connection that employee assistance and wellness, you know, that's really looking at the whole person, and the importance of behavioral health cannot be left out at all. What I would also add, though, to Mary's comment about the exchange, though, and whether or not an employer chooses to go to the exchange or shift the burden of the finances there, you still have a workforce that spends the largest part of their day at work, working in your workspace, and that opportunity to influence that environment in a positive way, or to build upon Mary's comment a few moments ago about that culture of health, that to build upon an environment where employees feel compelled to make the right choice about their health in the course of a day is really key to making health, having them engaged on a daily basis in their health, and not just when there's a health issue or something's come up. And it can be such small things that, you know, you can talk about putting in a fitness center or having, you know, a healthy cafeteria and healthy vending, but it can be such simple things that are around helping employees improve their energy in the course of a day. You know, you could all stand up right now, stand up, increase the blood flow, and sit back down, and you'll find yourselves actually more engaged in this conversation. But things where employees feel that making the right choice about their health, that culture supports it, having walking meetings, having, you know, rooms where there's weights that people can just pick up and move around, those are simple things that everybody can do regardless the size of an employer population.
Taking that tack, Josh, Target is really three different types of companies. It's a headquarters company, it's a company of distribution centers, it's a company of your stores. Mm-hmm. How, through wellness and the productivity strategies at Target, are you designing programs for each segmented population, or do you take a broad brush?
Yeah, it's a great question because there's different challenges to each group. What we've tried to do is when we created our well-being movement is we had one champion for each location. And what we were able to say is, like, we know no one store is going to be the same as another store. And so to say, hey, you are stores people and you're manufacturing people and we're going to treat you differently, we just realized that doesn't work. And so we've tried different segmentation strategies, some of which we've used from United. But what we've really learned at the end of the day is that if you've seen one store, you've seen one store when it comes to the culture of health in that location. So we've really we've kind of empowered what we call a champion, which is one person in each store who could kind of set the tone and set the cadence for that location, and we support them, we give them materials. But I think the most important thing, and to kind of pile on to what we've been talking about, is really what's our responsibility as employers. And here's the deal. It's pretty simple. We hire people when they are in their mid-20s or 30s. They come in with 25 or 35 years of their health habits. So whether it be they're smokers or they're overeaters or they have high cholesterol, we basically get them midlife when a lot of their habits are already created. So part of our responsibility is to work upstream. Downstream. So how do we work with schools, right? Like, how do we work with food choices? But then the other side is, like, there's no way any incentive I have, I don't care what I put into my, our annual, I'll pay for your biometric or health risk assessment. I'm not going to change your behavior through open enrollments, but what I can do is introduce concepts to you that you could just try. Right, so like we were saying, simple things like, we're working now, I'm trying to get permission just to put signs on the elevator, the outside of the elevator doors, saying, hey, the stairs are right around the corner, right? Simple little suggestions that you just get them to try it once. Or you bring in the green leafy vegetable into the cafeteria. You can't force them to eat it, right? But maybe you can make it at a price point that's equivalent to the pizza or the hot dog, so maybe they'll try it one day and maybe they'll actually like it. And so, to me, I look at it like I'm the principal of the school or the mayor of the town, and I have 350,000 lives that I'm accountable for, 8 hours a day. And so what could I do just to introduce a little bit of health and well-being into their life? And if they try it and they like it, they're going to pursue it. But I well know that we cannot force wellness or health onto anybody.
We have a couple of questions from the audience, so let's start there.
Well, you're right, by the way. Standing up, I feel much more engaged. What I'd like to ask, first of all, is what do 2 to 5-year-old American children have to do with this conversation? And there is a connection. I think it's even more of a connection than Jimmy Buffett. And that is, in the last 5 years, 2 to 5-year-old children were the one and only group of Americans that did not get fatter. Everybody else did. Now, I've been hearing variations of this same conversation since I came to the first IBI forum. When I went to the J.R. Simplot headquarters building in Boise, Idaho 23 years ago, they had signs by the elevators that said, take the stairs for 1 floor up or 2 floors down. Does the ACA, this is the question I want to ask, does the ACA somewhere in what it is doing and all the changes it is making in the way that it is sending up flares that say, hey, things are not going to be the same after this as they were before, does that provide anywhere any kind of leverage where we can take the glacier of American ill health that has been grinding down the valley for these many years and at least stop that sucker from moving any further, if not turn it around? Is there anything here that can make the future different from the past? Because the past has been exactly the same for the 20-some-odd years that I've been observing this very closely. And I've been to a lot of these conversations, and everybody still gets sicker and fatter, and more people have metabolic syndrome, and more people progress into type 2 diabetes, and doesn't change. Is there any hope?
So first of all, I'll start, because yes, we agree. That was well stated. The thing that we take for granted, and I don't think people think of like it's an ACA change, but is preventive care having to be free, right? So a lot of us moved that direction because we smelt the wind of change and we said it's right, but that's huge, right? So that preventive care is free. So every American should have access to free preventive care. So what that should do, at least once you become of age and you require the insurance, it should provide some type of stopgap and potential improvement. But I think the point that you're making that's well heard, and I don't think anybody in this room will disagree, is that we have to start with our kids, right? Because it's those kids who grow up to have heart disease and diabetes, and how do we prevent it? And no, the ACA isn't focusing enough on that. And we as employers have a responsibility, we as a country have a responsibility, and I think you're starting to see, I mean, 5 years ago you couldn't even have a conversation about a kid being overweight. But now it's part of your normal pediatric visits, that pediatricians are comfortable now telling a mom that your kid's overweight and you have to change that. 5 or 10 years ago, you couldn't do that. So slowly we're making waves, but we have a long way to go.
Yeah, I'll address that as well. The law shouldn't overstep its grounds in terms of legislating health and the like. What I think the law does is a very good job, though, of creating the environment that rewards. And I'm going past the issue of the allowances for incentives and the like. It allows for motivated people to be rewarded when they take action, such as when they get engaged, when they do what's right, when they mitigate their risks. They're going to be protecting themselves from what they're going to be spending on their own through the system. I don't think the law gets in the way of that, even though that there's more in the way of a community rating methodology, or at least more compression of the rates. I still think that the law itself is changing the way in which people look at health care benefits from being less of an entitlement and more of a responsibility. Mm-hmm. And that those behaviors, those responsible behaviors that you were describing, are behaviors that get rewarded in the way in which the system is evolving.
Great. We have another question.
Good morning. Good morning. This is Nim Patel. Thank you, panel. Wonderful comments. Dick, question for you. Based on our journey so far with the exchanges, private, public, are there any learnings that have surprised you, and do you think that the program may look different or could be different based on what we're learning so far in the future?
Thank you. I think some of the early learnings on this are to be patient. We had some starter steps going forward with technology, but the deeper issues are going to be on what happens with the likelihood of people taking their initiative to buy their care. Are we dealing with the high risk plan that's evolving? That's really going to become just a new modification of a high risk plan. And I think what we're seeing is the evolution. I think the biggest thing that we've learned is to be patient. Our own participation has been to be very deeply involved in the private exchanges. I think we're seeing some very interesting market activity there. I think people given information do act as good consumers in those environments. Our position has been in the public exchanges is to participate and to get deeper involved as those markets mature. And I think it's just a matter of being able to be adaptive and responsible. But clearly one thing that we all know with these exchanges, the law itself does not encode enough about cost containment. So irrespective of what system we have, we really have to be investing on the hind end in terms of getting the cost down by working up with capabilities that improve the health status, to take reversible demand out of the system, to provide tools of transparency so people who do use the system use the best parts, and then to make a very deep investment in the delivery system so they're at the top of their game when these people show up.
Hi, I'm John Hirsch here of Continuance Health Solutions. There's a lot of, it would be fair to say that the ACA is rife with incentives and disincentives. And it's also fair to say that what we're talking about, especially in San Francisco, seismic changes in the way in which we think about healthcare. The question I had is, to what extent is the Cadillac tax informing the conversation. Because when we look at that threshold and the rate that it's going to go up at a couple points a year, and we look at the way that medical costs have tended to go up, unless we take some fundamental changes, which what we're talking about, right, the root causes that you just addressed, it seems like at some point that line would get crossed unless we do something radical.
That's a great question. Josh, maybe from a Target perspective, you might want to try to...
Yeah, I mean, it's something that we definitely have analyzed and we watch for. The beauty for us, though, or the beauty or the curse, depends on how you look at it, is we have 2 plans for all team members, whether you are our CEO or whether you're a cashier. And so it doesn't necessarily affect us greatly. There's some questions in the back left.
My name's Tanya Barham. I'm here representing a municipal government, Multnomah County. The city of Portland, Oregon is in the county. And just from the employer side, I just wanted to bring up and have you guys comment on this, just how complex this can really be in incorporating the ACA and then boots on the ground. So in a political organization, we're obviously very risk averse because of the high level of scrutiny from voters. There's no single joint benefits board among our 11 collective bargaining units, so we can't make one decision and move forward. I think we administer 9 different health plans. We have no latitude to make huge plan funding shifts because we have people like jailers, so we can't just bargain. If they don't agree, we go to arbitration, and then it's up to a judge. We can't really pay people to exercise. I know like the average incentive now, thanks to ACA and just the market, is around $500 per employee per year. There's no way that we could spend millions of dollars on incentives and have voters say, awesome, Multnomah County employees get $100 to work out on taxpayer dollars. And we have a lot of programs. We have EAPs, we have fitness centers, we had that, but for the past 10 years, our uptake was never better than 5% of our employee base. So I just wanted you to comment on, there's a lot of theory about strategy, about data, but even if you have access to that, I really feel like when I hear from employers, the differentiator is what Target talked about. It's those champions at each location, or even Comcast last night said, we were literally on the phone calling every single person on our disability plan. And it's not fancy, it's not a program, it's not a lever, but it's a lot of using that strategy to organize and do a lot of hard work. I mean, thankfully in Multnomah County's case, we're a political organization, so we know how to organize people and get the word out fast. But I just wanted you guys to comment on that. I think there's a lot of talk of ACA, but what happens when the rubber hits the road and you don't have a lot of latitude to make decisions based on the structure of the organization?
Well, we work with a couple of, in particular, I'm thinking of a couple of county governments in Florida that we're working with. And to your point, there are not a lot of excess dollars to use to provide incentives, but the folks there did a lot of work with data to bring to the commission board the statistics that showed what could be saved with better health as an investment in the employees. And then they formed employee teams for every single department. So realizing that having an on-site fitness center at the county seat does nothing for the people in the Parks and Rec division who are out on the road all the time, every day, they allowed each team to develop the strategies they wanted to pursue, to engage in improving health and other wellness and financial incentives. And the incentives were pretty modest. I mean, they were giving out Starbucks gift cards and things like that, but it was the team, in each team, that came up with the ideas and got tremendous support from, from the directors of benefits there to implement those programs, and then come back to the Board of Commissioners at the end of the year and show how they were able to control healthcare costs with a very modest financial investment.
There's a very interesting, I know, Alex, we're going to cut it off in just a second. There's an interesting thread throughout all the comments today, and I think your question from a public sector perspective, it kind of resonates, and the issue is leadership. In order to be successful with everything, whether it is public sector or in a commercial environment, there has to be a degree of leadership, and it has to start somewhere. And oftentimes it is the person who inventories the various programs and says, what are we getting for doing all of this? So it is easier in the commercial world in many respects, but in the public sector world, there are people who are taking a leadership role and being the voice around improving health and productivity of the workforce. And it's a little sticky wicket, but leadership is really, really critical there.
Yeah, and I would just add to that leadership at all levels, because leader doesn't necessarily mean it's got to be the top dog in the room. I mean, leadership really at all levels, grassroots leadership as well as senior leadership.
You betcha. There was one last question.
I'm Jim Franklin, and I own a small business. And my feeling is that the impact of ACA on small businesses could be a lot different than on the macro level that we're talking. What are your opinions on that?
I mean, it depends what you're thinking about. So, you know, if there's a $63 tax per individual, I have a couple 100,000 employees. That's a bigger impact on a larger employer. If it comes to how many people do you have on your team to be analyzing and reacting, well, you know, I have 3 or 4, so it's probably easier for me. I think it has an impact on everyone, and I think the key, somebody said it here, is do you look at this as a challenge and you're going to say, woe is me, or do you say, it's a law and this is an opportunity and it's going to allow me to reset my business and say, how do I serve my employees in the best way that I can? And so yes, it impacts all of us, but I think if we embrace it and say, take this, galvanize us, and let's use this as an opportunity to maximize our productivity, maximize our benefits, and maximize our approach to our employees' health, I think we all win.
Thank you.
Thank you, John.
Thank you.